Good afternoon. Welcome to all who you have joined us in our 168 since the Andean Health Organization Polito Unano Agreement started the cycle of webinars in May 2020. In association with Health for All, strengthening primary health care to build resilient systems. The COVID-19 pandemic teaches us the capacities built and strengthened in these 3 years should not be rolled back.
Salud debe continuar en el centro de las
And health continues to be at the center of policy, research, epidemiological and genomic surveillance, development of vaccines and drugs, deployment of prevention measures, and good communications are essential for a caring society. Reflections on these and other priorities relevant to health and well-being can be found in the monthly Notisalud Andinas newsletter, available on the Andean Health Organization's website. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube Live chat. In the same space, you can leave your questions or send them via email to webinarhorasconu@gmail.com. In this webinar, we will follow the usual dynamics. We will start with institutional greeting, followed by the lectures of our speakers, and then we will move on to the Q&A session. To a certificate of attendance, as usual, in any of the chats of Facebook Live or YouTube Live, you will find a fixed link. Fill out a brief survey and then leave your data for the issuance of the certificate, and it will be sent in the coming days to your email. To start this important day, I give the floor to Dr. Maria del Carmen Calle, Executive Secretary of the Andean Health Organization, the Polito Unano Agreement, who will give the welcome and institutional greeting. Go ahead, Dr. Calle. Thank you very much, Marisela. Morning, good afternoon. Welcome to the webinar number 168, Health for All People, Strengthening Primary Health Care to Create Resilient Systems, that Orasconu is pleased to hold today. Primary health care was conceived in the 1970s, a political strategy to achieve the social goal of health for all. It responded to important changes in the social, political, and economic fields that occurred globally after the Second World War. PHC is a society-wide approach to health that aims to ensure the highest attainable standard of health and well-being, and its equitable distribution through care focused on people's needs as early as possible along the continuum from health promotion and disease prevention to treatment, rehabilitation, and palliative care, and as close as possible to people's daily environment. PHC is also critical to making health systems more resilient in crisis situations, more dynamic in detecting early signs of epidemics, and more prepared to act early in response to surges in demand of services. Although data are still lacking, there is a broad consensus that PHC is the front door of the health system and the basis for strengthening essential public health functions in the face of crises such as COVID-19. PHC is the most inclusive, equitable, cost-effective, and efficient approach to improve people's physical and mental health, as well as their social well-being. There is growing evidence from around the world of the broad impact of investing in PHC, particularly in time of crisis such as the current COVID-19 pandemic. A health system based on primary health care orients its structures and functions towards the values of equity and social solidarity, and the right of every human being to enjoy the highest attainable standard of health without distinction of race, religion, political ideology, or economic or social status. States have committed to renewing and expanding primary health care as the cornerstone of a sustainable health system to achieve health, universal health, the health-related sustainable development goals, and health security. This commitment has been formulated and reiterated in the Astana. Globally, investments in PHC improve equity and access in relation to health service, healthcare performance, health systems stability, and health outcome. This year's World Health Day, April 7, has as its theme Health for All, and WHO is celebrating its 75th anniversary under the theme 25 years of improving public health. We agree with what the director of PAHO said on that date regarding the need to develop and achieve health systems that have the capacity to prepare for and respond effectively to an emergency, maintain basic functions when a crisis occurs, and reorganize and transform themselves if conditions so require. Countries must strengthen the stewardship of health authorities, the governance of health systems, improve social participation, and ensure integrated health services focused on primary care. In the same context, the Horas CONU is also holding this event to discuss ways to strengthen and transform health systems in the region using the primary healthcare approach, face current challenges, and prepare for future health emergencies. With the participation of excellent and renowned professionals in this field, Dr. Eliasen, Director of Health at the Copenhagen Institute for Future Studies, Dr. Lidia Campodonica, Director of the Department of Primary Health Care and Family Health, Faculty of Medicine, University of Chile, and Dr. Gustavo Rosell, former Vice Minister of Public Health and International Consultant in Health System. Again, welcome. Thank you so much, dear Dr. Calle. After the greeting of our Executive Secretary, I introduce myself. My name is Maricela Malki. I'm the Deputy Secretary of the Andean Health Organization, and today I will be very pleased to be in charge of moderating this webinar. After this preamble, we will welcome Dr. Boji Eliasen, the Director of Health at the Copenhagen Institute for Future Studies. He was born in the Faroe Islands and educated in political science and international law at the University of Aarhus, Denmark, where he received his master's degree in both fields. He also has executive education from the Harvard Kennedy School. He previously worked at the Ministry of Foreign and Commercial Affairs of the Faroe Islands and worked as a consultant for the last 20 years for politicians, public sector, and private companies. He initiated the first global population genome project, PARGEN, to sequence the genomes of the entire population of the Faroe Islands. He has promoted the Nordic Health Movement 2030, which drives fundamental change in preventing health. He received the HIMSS Future 50 International Achievement Award in 2019 for his long-standing commitment to the digital transformation of health and care. He is a member of the Global Bioethics Network, chair of the INSS network in the Nordic countries, and of the steering committee of the Phase 5 of the health studies, as well as co-chair of the Skiana Health Leader Network, the network of health leaders in Europe, among other international positions. Chief Health Officer of CIFS, he has a holistic view of the future of personalized and preventive health, focusing on data, digital functions, and genomics, and their integration with health, which has embodied in various projects and networks around the world. Go ahead, Dr. Boyack. Have the floor. Thank you for the invitation for this important event. And I would like to take some minutes to give you an overview of future how to arrive to primary health care, because this is, as it was mentioned at the beginning, this is extremely important. And you know me, you know that Latin America is very close to my heart. And also I see many opportunities, not only to improve, but some opportunities to lead in how we can work with primary health care in a more equitable way. Well, as it has been mentioned, I work in the Copenhagen Institute for Future Studies. It's for the 5 decades working at looking and helping, looking at the future and helping decision makers to arrive to better results. For us, as a health team, we have an approach as health as the most important pillar for society, for equality, equity, justice, sustainable growth, and prosperity, as it has been mentioned at the beginning. Also, to focus on the reality of well-being economy. And this is not to have the first approach of hospitals and treat diseases, but to reduce the more avoidable morbidity burden. We also have an approach of not only innovation, but also in the application of innovation and the knowledge we have, because we have a lot of data, we have a lot of technology that we are not using, and that doesn't help us. We also know that chronic diseases are our highest burden, and in here we have a very large approach in which we state secondary prevention that has many definitions, but we know that when a person has a chronic condition, we know that you're going to get to secondary prevention. So our approach with primary care, with all the data that we have, to try to approach that space with early detection and screening, either to prevent that people go have their first chronic disease, or that we can stop the progress to the second chronic disease and then help the systems. That is an approach that we have for this year, if we can carry out with several partners. But that has to do with the most important question that we always ask. What do we want? A better health system or a healthier population? And of course, that to approach primary care or focus in primary care is because we want a healthier population, but we also want strong health systems. But that is to have the population healthier, not necessarily to have the most advanced hospitals in the world. We cannot push that part without thinking in sustainability. And that has many aspects, have to do with health. This carbon footprint, the better use of resources, creation of value, but it's also to decrease the morbidity burden with health coverage and the available morbidity burden decrease, and to look at the health as an investment. How can we produce value with health investment? And here, we are trying to look at concepts that world organizations use and some concepts that we have developed. For example, we have the prevention part of avoidable disease burden. We have the sustainable development goals. We have the economy of well-being, with health in all policies. But we also have other models that we have developed in our Nordic effort with a 50-50 or 5-5 model that's trying to move the budget, health budget, from 100% for hospitals, half for prevention, with primary and secondary and tertiary prevention, but prevention, in order to have more health in our society. This model of 80-20 that we know that for most countries, we have 20% that requires more intense treatment, but 80%, with a little effort, it can be maintained with good health for longer. How can we look with the data that we have in order to do a better job? And the equitable perspective are extremely important, of course, universal health coverage and leaving no one behind. But there is another concept that we have developed of 1090 model. If we look at the companies and university, they are focused in 10% of the riches of the world. 90% are left as outside the focus of how to solve those problems. So we are also discussing with these organizations and companies of how can we focus more in the rest of the world. For example, when we look at Latin America, there's more than billion of inhabitants with problems of health, a large area. And there, the health determinants are extremely important, with social determinants, One Health. And that changes, what has changed the world is that digital data and other technology that on how we can improve the life of many. There are other parts. So if we want to make those changes, those systemic shifts, we're going to have to work together with some principles, criteria, concepts that we can accept and push those parts in order to have these approaches with the goal of equitable and equality, concepts that we have all been talking for 30 years but haven't done much with regards to health determinants in pushing for how working together. I will focus more on data because with the explosion of artificial intelligence in recent months, we need to focus data governance and do it well. How can we use those new tools for good that can help our systems? And that needs investment, need to work together. We need to work between the private and public sector. We need collaboration between countries. And I'm a big fan of ORAS and the work that they do, but that also has to do with principles. We use a FAIR principles: findable, accessible, interoperable, and reusable. So there are criteria when you receive funds to work with data, but it is also the training of the individual, technology, society, of how to work with health instruments and technology, and with the protection and use, and how we're going to be working with the sports. And of course, that this approach also for primary healthcare has a lot to do with prevention and early care and early detection. And we also know that with the technology that we have and what we know we can use better, we can identify, start treatments where they are needed with less resources and earlier. And this is extremely important. We need to work together to get there. And as I mentioned, there are many people who use Spanish as their health language, more than 500 million. And that means that this is the largest language after China. So it's very interesting to work with Latin American countries. When you are in Latin America, they say they're quite diverse, but for me, they're very similar, but the problems and challenges are very similar, and that we can work together for data governance, because we need to see how we work with this data. Everyone needs a better infrastructure for digital tools, and that can be worked together, and a social contract of how we work with health and data in order to improve together. I think this is a great option to push for primary healthcare, because the approach for the future, from my perspective, is to have the right to a healthy life where the access to the right treatment is a priority to have health. But the access to treatment is a tool, it's not the end in itself. And high technology primary care should be a priority. Now we put high technology in hospitals, but we should think much more in how we can put technology that is not necessarily expensive in primary care. So primary care of the new generation is a high technology of user-friendly with telemedicine, new biology, and territorial health coverage. And that seems to, for me, the approach that we need. Thank you very much, and I'm ready for any Q&A. Thank you very much, Dr. Boji. You have presented a different vision of health, some considering the health as the most important pillar, which we continuously repeat from our institution. Because during the pandemic, indeed, health was at the center of the policies, but unfortunately, we see how they're losing leadership. You have reminded us that chronic diseases that represent the highest burden and represent almost 70% of deaths throughout the world. And a very important reflection, what do we want? What are we looking for? Better health systems or a population that is healthier? Perhaps as a virtuous circle, improving health systems to have healthier populations. And this leads us to the part of technology, which is more current in this time, with the boom of artificial intelligence, to look at data governance that should actually help to solve the problems, and what also how important collaboration is between institutions and countries, something that we cannot leave aside with regards to prepare the society with the use of this new technology and data protection. And you mentioned that we are a very important population that speaks Spanish, and that should bring us together to analyze and use technology in favor of the health of the entire region. Dr. Boyas, thank you very much for what you mentioned. We ask you to please remain in the room because the Q&A will come at the end. Thank you very much. Thank you. Now we give the warmest welcome to Dr. Lidia Campodónica. She's a surgeon specialist in family medicine from the University of Chile. She's the director of the primary care and family health of the university. It's in charge of the program of community of practice in primary health in Chile. We promote collective learning through the interaction of several stakeholders, facilitated the identification and documentation of experiences in primary healthcare as a meeting and discussion point for policymakers, managers, researchers, and health science professionals in Chile. She's an advisor of the Ministry for the Universalization of Primary Healthcare. She's been a consultant in WHO, PAHO, and some consultancies of primary healthcare. She's been the head of the technical department of health of the South Metropolitan Primary Healthcare in San Joaquin, in the metropolitan region. She's been working in the implementation of these models, the primary healthcare training. She has drafted a number of ministerial documents. Dr. Campodónica, you have the floor. Thank you for the invitation. Share some insights with regards to this complex health for all, how to strengthen primary health care in order to build resilient systems. Our country, Chile, has more than 18 million inhabitants with a public health system that serves 80% of the population. Indicators, if we look at with different communities with high resources and high socioeconomic level, with communities that are vulnerable and poor and rural, these indicators differ substantially. Challenges of our countries and of the health systems is the aging population, the high prevalence of chronic health problems, the two aspects, increased requirements of care and innovations of care, and the major problem of inequity, which linked to social justice. Here we can see this comparative chart of health issues and population with less than 8 years of schooling or more than 12 years of schooling and the highest burden of disease is focused on those who have less than 8 years of schooling. For example, hypertension, it has 51.1% prevalence. And in the population with more years of schooling, it's just over 16%. And the same for dyslipidemia, ECT, with 35.5% in those with less than 8 years of schooling, compared to 18.5% in the population with more years of schooling. Metabolic syndrome, 47.8% versus 26.4%. Chronic respiratory symptoms, also a remarkable difference from 37.2 compared to 18%. Like GI system, hypothyroidism, depressive symptoms, and here's something really painful, which is the cognitive impairment of the elderly with 17.2% in those who have less than years of schooling versus 3% in the population that has 12 or more years of schooling. So we see that the population that lives under vulnerability conditions, especially poverty, and with major disease burden and disability and early death that can be avoided. In the Astana conference, primary healthcare strengthening is the most inclusive, effective, and efficient approach to enhance people's physical and mental health, as well as social well-being, and that primary healthcare is a cornerstone of a sustainable health system for universal health coverage and health-related SDGs. There is accumulated evidence on strong primary care in its essential attributes of access, coordination, longitudinality, and comprehensiveness. And the evidence shows that it improves people's quality of life, reduces the overall mortality rate, reduces avoidable hospitalizations, and improves the quality of health services. However, primary health care is still undervalued, culturally undervalued, and we continue to train our health professionals in hospitals and with a biomedical approach, and they don't have the tools to work with the community in primary healthcare and make them to participate in their care, to work as a team, and to understand the multifactoriality of the health problems, and they don't know how to take care of their health. And we talk about universal health coverage that is built on universal access to services. Without universal, timely, and effective access, universal coverage becomes an unattainable goal. This was stated by PAHO WHO 2022. And this is a major problem. How can we do this? How can we facilitate access when there's so many barriers of several types? Move ahead in universal coverage. In the 9th PAHO Summit of the Americas, June of last year, which was building a sustainable future, resilient and equitable future, Dr. Carissa Etienne stressed that the summit theme reflects an unprecedented urgency for us to address long-standing inequities in the region through sustained action to build resilient health systems and societies. Here, the issue of inequalities is extremely important in the social determinant of health This is not a problem of the health system itself. This is an issue where all the sectors should be involved, education, housing, etc. So the inequality, as we mentioned before, comparing poor populations with populations that have a better socio-cultural level, that needs to be approached. We need to improve how can we give that population better opportunities so they can live a more pleasant life. So, what are we talking when we mention resilient health systems? It has been said that for health systems, resilience is defined as the capacity of a health system to absorb, adapt, and transform when exposed to a shock or a crisis and still maintain control over its structures and functions. So what do we understand for absorptive capacity? As the capacity of the system to continue to deliver the same level of care in quantity, quality, and equity despite the crisis suffered. And that is a major challenge, how to approach this. When during the situation of pandemic, we were not able to do it. So chronic controls were discontinued. Many activities for promotion and prevention were discontinued. So we require training in this area for decision makers at the level of public policies. How do we approach this? Adaptive capacity, we understand it as the ability of the stakeholders to guarantee the same assistance with less or modified resources, which implies making organizational adaptation to maintain the same care or assistance with less resources. And transformative capacity is understood as the ability of stakeholders to transform system functions and structures in response to a changing environment. We know that primary health care, the primary healthcare teams and their communities live in situations of constant uncertainty. In another statement or declaration from PAHO, indicated that to strengthen or transform the organization and management of health systems to develop the models of care focus on the needs of the people and the communities, increase of the resolution capacity at the first level, coordinated with integrated health services networks, and based on the strategy of primary health care, is something that we need to do. It is not possible to increase the access to comprehensive health services if care is just curative. It is impossible. We have 11 million people with chronic problems. So we need to include promotion, prevention, and also change the paradigm of the biomedical approach towards the approach of the healthcare and intercare, how we take care each other. In Chile, we are going through a reform process of universalization of primary healthcare. The government program of President Boric states among its objectives the universalization of primary healthcare, which aims to achieve universal access and coverage, and to redesign the governance of health policies so that primary health care becomes the basis of the health system. So we need political decision. It's not possible to establish goals in the health system without a political support. And we need all the support and resources for professional training infrastructure, etc., in order to move ahead in this regard. In this context, the Ministry of Health started a process of reform for the universalization of primary healthcare, structuring different technical and political instances for the achievement of this objective. For example, we have 11 million people with chronic diseases. In the National Health Survey, the changes are comparing results from 2010 and 7 years later. What happened with this population? We lost the audio. Please stand by.
Doctora, ¿puede revisar su micrófono? No se le
We cannot hear you, Dr. Campodónica.
de repente tenga que salir y volver a entrar un instante, es mejor. Esperamos, por favor, unos instantes.
Let's wait until Dr. Campodónica returns to the
Esperamos un minuto más y vemos si puede
let's give
continuar.
her an additional minute.
Termina después.
Please stand by.
De repente le podemos pasar la presentación desde acá.
¿Volví?
Sí. ¿Está otra vez con nosotros?
I'm back? Yes.
Sí, estoy en el sur del país.
I'm in the south part of the country and we don't have a good connection here.
Los niveles de conectividad son diferentes. Bien. Para
Okay.
compartir, ¿se podría agrandar o no la presentación?
Sí, puede. Sí, puede.
Yes, go ahead. Go ahead.
No sé. En todo caso, para mejorar de repente, tenga que apagar su cámara para que pueda tener mayor seguridad en la conectividad.
Usted está viendo. Ya, me parece que hay otra persona que está compartiendo mi presentación para que avance, por favor.
Sí, usted avisa que avance y avanzan desde acá.
Sí.
Okay, so we will continue.
Muchas gracias.
Thank you.
Entonces,
So 11% of the hospital discharge are from available hospitalizations, and this has a major social gradient with a high impact in communities with higher vulnerability. Avoidable hospitalization represents around the 20% of the hospital beds used per day. That corresponds to 69,000 surgical discharges and represents an avoidable expenditure of $300 million. 1 out of 3 people with avoidable hospitalizations die during the hospitalization, confirming the evidence that hospitalization that is avoidable represents a major risk for that person. Next slide, please. In the government program, the commitment is the universalization of primary health care, where PHC will cover 100% of the population. And with that, it will become the basis for health care at the territorial level, promoting actions of promotion and prevention, being the first point of contact of the health systems. There is a political commitment. We will strengthen the primary health care by improving the availability of resources, updating the family health plan, and continuity and integration of care, and to improve the mechanisms of equitative allocation for territories. So we have defined 7 working axes for universalization. Universalize primary healthcare coverage to 100% of the population of the territory with no type of differences. To promote universal access through technology of information technology, screening in working areas, among others. With a new care model is being implemented throughout the country, the ACICEP, developed by the Catholic University of Chile, that stratifies according to the risk, the population that suffers of cardiovascular conditions. Therefore, prioritization and treatment is done according to this. And to update family health plan with a new model of management with updating of indicators and health goals. It provides coherence where we're talking about a person-centered system, and the indicators measure results. Technical integration with other levels with a national data repository, telemedicine, which is so needed in our country. Improving financing of primary healthcare with improving the allocation per capita, improve indicators, and stratifying and allocation by risk. And 7 is to close the gaps of human resources, infrastructure, and equipment. Therefore, this is to talk about resilience. Is a major challenge, and here we need to act together with other sectors, especially with education, but from the public policy, from the integration of public policies, housing, development, etc. Thank you very much. Thank you, Dr. Campodónica, for your excellent presentation. You reminded us how your country, although have good indicators, they still have major challenges, which is the aging of the population, the increase of chronic disease prevalence, and inequity, which we see in several areas of our region. So that in the meeting in the PAHO, where the director called for an urgent action to approach these inequalities, not only health, but with the contribution of other sectors. And you also reminded us resilience of health systems, to absorb, adapt, and transform in order to continue with their effort. We don't what we had to pandemic, and that should not happen again, and move from a biomedical vision to a vision with emphasis in promotion and prevention. You also mentioned what Chile is going through with this reform with regards to the universalization of primary health care with 100% coverage, focus on the territorial level with the priority of prioritizing prevention and promotion. You mentioned that it has 7 working axes for this universalization, and I think it is important to remember primary healthcare becoming universal, going to universal access. They're working on new models of care with a new model for managing. And you mentioned that we still looking at health at a different perspective from the university when it actually has a different view. And also having better financing for health care. We know the benefits of primary health care that improves quality of life, decreases general mortality rate, decreases avoidable hospitalizations, and you show the cost involved in all of it. It's also important that we have insisted during the pandemic is closing the gaps in terms of human resources, infrastructure, and equipment. We hope that we've learned something from this pandemic, and that our governments can work for closing this. Thank you very much, Doctor. We ask you to please remain in the room for the final portion for comment and Q&A. Now, I'm going to welcome our third speaker, we want to welcome Dr. Gustavo Rosell. He's a physician at the Universidad Nacional Mayor de San Marcos, international consultant in health systems. He has served as Vice Minister of Public Health on 2 occasions, has been a Deputy Superintendent of the National Superintendents of Health, the Director of Strategic Interventions in Public Health of the Ministry of Health. He also been the Regional Director of Health of the Regional Government of San Martin, Director of the General Hospital of Pasco, Director of Health Networks, National and International Consultant for PAHO, WHO, WFP, GCTH, UNAIDS. He has a master's in public health from the Institute of Tropical Medicine of Antwerp, Belgium, diploma in international health from Harvard University in Boston, USA, National Health Leaders Program, PAHO, WHO, specialization program in epidemiology in Lima, Peru, and also a specialization diploma of government science and global governance and International Institute of Government, IGOB, in Lima, Peru, among other responsibilities. Dr. Rosell, you have the floor. Go ahead, please. Thank you. Good morning. Thank you, Dr. María Carmen Calle and her team. Greetings to the speakers and participants. I'm going to talk a little bit about primary health care. We are all convinced of its importance and the need to continue with its implementation in our countries for the improvement of our health systems. But let me start with some background. I always like to start with this because it rescues the spirit of primary health care. It comes from way back. Primary health care has many years. And perhaps the most that we most remember are the experiences during the major depression in the 1930s, or the barefoot doctors in China that was pioneer in training of rural village health workers. This model was developed and institutionalized from 1965, where people who receive basic medical training for 3 to 6 months full-time and work where physicians could not reach. Remember that almost 90 years ago, it was a country with a lack of deficiencies, and most of them in terms of human resources. So they included farmers working barefoot in the paddy fields, healers, rural healthcare providers, so they could reach to those places where they were required. They promoted basic hygiene, preventive health, the common diseases, and they provided vaccines, childbirth care, and improved hygiene. And part of the essence of primary healthcare to cover basic needs, primary needs of people. And in Peru, we had an experience that was also pioneering in 1933 in a region of our country, in Puno, in the province of San Román, with Dr. Manuel Núñez Butrón, who's considered a pioneer of PHC in the world. And he worked with the purpose of improving the physical and mental health of the native, declaring lies, alcohol, and illiteracy as enemies. So he worked on social determinants in the cause of the health problems, especially those who work in isolated areas, remote areas, and many of them were illiterate. 5 commandments were not to be liars, not to be thieves, not to be idle, not to be litigious, and not to be slovenly. This part of the Inca moral. And the promoters were taught about body hygiene, minor healing, injections, and vaccines. In schools, they taught to read and write, how to make different activities, vegetable gardens to improve food. They did not only approach diseases and health, but also it included social determinants. And this was published in a Runa Sonko journal. So the Richardson or awakening is one of the important background information of primary healthcare in our region. And as Dr. Maria del Carmen mentioned, it was systematized and was major drive of what we all know as the International Conference of Alma-Ata in 1978. And although it made some utopic proposals, we consider that as the desire of everyone of having a complete physical, mental, and social well-being. Perhaps we will not reach that, but we should mobilize all the resources in order to protect this fundamental right, which is people's health. So get the involvement of many other social and economic factors, because health is not just the property of a group of people or a ministry or science or intellectual, but health, of course, belongs to each one, to their families and communities. Therefore, we all have this co-responsibility to promote health. And in Peru, one of the persons that I think that has greatest influence in training of primary health care professionals, we listened to Dr. David Tejada Rivero, who mentioned, and he was one of the organizers of the Alma-Ata event, that the term was primary health care, whose translation changes significantly. When it was translated to Spanish, it lost its spirit of this concept. The original term care of care and not attention. Alma-Ata considered primary as essential, nuclear, fundamental, substantive, and priority, and not a health, a disease-oriented restorative medical care. So we consider it as the essential care of health, and it's a comprehensive health care for all and by all. And of course, it has to be included in all policies in order to intervene in the major problems that have to do with violence, work, education, etc. As it has been mentioned, Alma-Ata has four basic aspirations, which are the major pillars of primary health care. So it has to do with government and societies that prioritize, promote, eh, and protect health and well-being of people, both of the population and individual levels, who have solid health systems. So we're talking about resilient health systems. Primary health care with high quality, safe, comprehensive, integrated, accessible, available and affordable for everyone, everywhere, delivered with compassion, respect, and dignity by well-trained, competent, motivated, and committed health professionals. In one phrase, we are actually describing what type of system we would want to have, what type of we should establish as a goal in management in order to respond to the people's needs. Only enabling a supportive environment for health in which people and communities are empowered and collaborated in maintaining and improving the health and well-being, with partners and stakeholders aligned in providing effective support to national health policies, strategies, and plans in a coordinated effort. That is not a utopia that we've seen, and this should be one of the learnings in the pandemic approach, when in Peru and many other places, the public and private health services work under the same governance, under the same organization in terms of vaccinations. We had a collaboration of companies, mass media, municipalities, regional governments, working in a coordinated fashion with a single purpose, which is first, save the life of people, and second, to avoid the impact that the pandemic was having in the lives of people. Also included, of course, jobs. And this is some of the pictures that we have of the meeting of Astana. And I think that it was a significant meeting to revalue primary health care. In this definition of primary health care, or is the approach that includes a society-wide approach to health that aims to ensure the highest possible level of health and well-being in an equitable distribution through care focused on people's needs as early as possible, along the continuum for health promotion and disease prevention to treatment, rehabilitation, and palliative care, and as close as possible to people's everyday environment, and reminds us that primary health care was born where people live. It was not born in the hospitals of health services. Primary health care was born in people who didn't have a health profession, but they were trained to deal with this primary care. Because remember that many of our infancy diseases were treated by our grandparents and our parents without the need to go to see a physician. How to take care of a child with a cold or diarrhea or a fever and others. Maria Carmen is a pediatrician. We need a pediatrician, but of course we do. But the most important essential care should come from the people's own care and their family, and then of course the professional care that we should all have, because there are situations in health that require this type of care. Primary health care comprises three interrelated and synergistic components. Coordinated comprehensive health services in which primary care is public health functions are developed. And here we include health services are not necessarily brick walls, but are also services that are provided and offered to the community. Multi-sectorial actions and policies in the area of health determinants in order to provide sustainability to health protection, and the dialogue with and empowerment of individual families and communities to increase social participation and improve self-care and autonomy in health. This is clearly seen in vaccinations, where vaccination definitely is a volunteer act, and we need to generate that trust, not when we have health problem, but trust since the people is born and trust the health personnel, trust their parents, teachers, because they see protection. So people should grow and thrive with this trust and that interrelation. Similar to what we mentioned in regards to technology, one of the important things of technology is that get us close to the person. When we work anemia, people that were responsible of caring for children had the WhatsApp of their parents, so they were linked using technology to personalize health care. We also mentioned about renewal of primary health care in the context of new challenges, knowledge, and context. The world in 1978, the world in the 30s is different. Different time points and the way how we communicate has changed. Therefore, we require to modify the methodology and strategies of primary health care in order to reach people. In the 1930s, 80% of people lived in the rural areas. In Peru, in this time, almost 70% of the population lived in cities. So the approach is going to change. Working hours change. I cannot have a health facility working from 8 to 4 because at the time people are working. They return to their homes at 8 o'clock in the evening. So perhaps in vaccination, we have vaccination schedules that started at 8 p.m. in order to be able to visit the people at their homes and vaccinate them. So there are different scenarios. The renewal of PHC requires to recognize and facilitate the important role of promotion and equity of health, access, justice, resources, political commitment, and a development system that guarantee the quality of care that has to be dealt and considered to generate this resilience in health systems that has to be oriented towards universal access to health care and coverage. I already mentioned by Dr. Lydia, but we need to have health systems oriented towards universal access to healthcare and universal health coverage. With the pandemic showed us, we know that no health system in the world was prepared to approach a problem of such size, and this was demonstrated. There was no single country that had the capacity to make an adequate control, and even less in terms of the social, economic, and psychological impacts. So in the future, we need to look at how these systems. We're not going to talk about some decisions taken in Peru, such as those the first level of care, when actually, from our perspective, what should have been done is to strengthen them. But anyway, and the ability of health sectors, institutions, and populations to prepare and respond effectively to this situation, and to see how the society organizes in order to face the problems, crisis, or that our country is quite vulnerable for natural disasters. And key health system domains for resilience. One is governance. Governance, not a synonym for government, governability, but governance is the set of institutional adequations that are required to manage necessary resources to take care of that population in an articulated way with different stakeholders. Governance is extremely important, and the methodology of governance that we believe should be done is in the territorial fashion, not by sectors, or in terms of territory. Of course, provision of services, infrastructure, financing, and resources are extremely important to generate this imply the commitment of government investment in such health system at the first level of care, but also with the capacity to prevent diseases and to promote adequate behaviors. So the approach of social determinants, reduction of risk in disasters and emergencies, strengthening of surveillance of public health and control of disease outbreaks, and the promotion of research on health system deficiency to look at these operational issues to see how can we optimize resources and make them more efficiently used. And of course, the work that we need in terms of the quality of services, which means decrease risks in those services, both as well as users and as well as health workers. And finally, to indicate that in Peru, in this first level of care, that as a matter of fact has to involve primary health care at every level. We have organized a national multi-sectorial health policy, and we have a model of comprehensive care, current model, and through the health networks, this national policy should flow in sectors to invest and do an adequate approach of health social determinants, to taking care of the needs of individual, family, and communities under the frame of a comprehensive care by life course model. We need to integrate all the process in the national management level as well as the regional government, subnational management levels, and also at the local level, usually organized in municipalities where the elected authorities that have responsibilities in this value chain for the implementation of process. And the specific result is a healthy population. And this has a broad action. It's very difficult to define a healthy population, but improving life standards, improving the quality of life, including the indicators as our colleague in Chile showed. Of course, we have a monitoring of those indicators, and we're able to improve until 2019 that unfortunately with the pandemic, there's been a significant loss of, because there was an increase in maternal death, but also in terms of processes and vaccination averages for children dropped dramatically during the pandemic, and we try to catch up in recent months. So it was important to generate this model that rescues primary health care because it centers all the efforts on people and not the health services, because it has the extramural effort by considering the needs of each person, family, and community. It makes investments in technology. So it's okay that we need health facility with X-ray rooms, but we also need people. And we have backpacks, and we can go to remote areas to take X-ray, for example, for tuberculosis, and to HIV. We have gene expert equipment that we can take to the communities, to those remote areas that are at a higher risk. This is what we can rescue through this model of how do we approach this system that has a pyramid shape, with a first level, which is usually outpatient, a second level, which is like the hinge between outpatient and hospitalization, and a third level with hospitalization. But unfortunately, the way we see it here, it contributes to fractionation of care. So we are proposing a more territorial organization with the integrated health network provided by PAHO, where the center is the person, the family, and the first level of care for essential care, but a first level that involves specialized care with public health interventions and the territorial action of against those determinants. So what we need to strengthen governance with territorial management. And to conclude, we're talking about comprehensive healthcare with interventions of people, the people, their families, and the community, towards people, community, but also the care of our own community. Talking about healthy school, healthy municipality, etc. We're looking not only for health, but health as a component of well-being and development of people, because our goal is always health, but we understand that health is a goal for people. We don't live to have health. We have health in order to live and to fulfill our desires and grow as a family. So health should be a comprehensive component of our development as persons, as a professional, but that is an end in itself. But as Schopenhauer said, without health, there's nothing. So this is a basic right that we should all be able to care for. Finally, we have organized in order to strengthen these resilient health systems, health authority organization, the territorial organization, the integral network organization. And this territorial organization is so important because we need to generate management teams to relate with the different authorities and to have an adequate design of care circuits, both for children, for adolescents, and actually to the entire family, because this territorial organization includes these procedures that have to do with the comprehensive healthcare. The organization of services, the flow of services in each area, and according to the needs of the people, and the implementation of the mechanisms of communication with people and families. We're always talking about humanization of personalized care, personal health, and that has to be sustained in this new technological development that allow us closer to getting closer to people and to look after their rights and their comprehensive care and respect to the confidentiality of the people, provide adequate information, evaluate their quality standards, and that makes these systems are able to adequate to the new demands that we see more. For example, one of the problems that we see in adolescent suicide attempt. So in Peru, we have started with community mental health center in the university. And the idea is to expand the systems in the schools, or at least to have some staff that will link the mental health care in children who suffer violence, or children that need to get ready in order to manage the problems they're going to see, such as rage, frustration, etc. So try to avoid the concept. Okay, thank you. Thank you, Dr. Rosell, for your excellent presentation. You have shown us from the history and concepts of primary health care, how the barefoot patients in China and the model in Peru. We talk about primary health care, considering health determinants. You reminded us the concept of health from Alma-Ata in 1978 to the Astana Declaration. In Alma-Ata, I mentioned that the health was a state of complete physical, mental, and social well-being, and not only merely the absence of disease. It was a fundamental human right that requires the intervention of other social and economic sectors. And also what the primary health care approach of health that includes the entire society and has the main goal to guarantee the highest level possible of health and well-being, focus on people's needs. And these are three components that are interrelated and are synergic: health services, multisectorial policies, and the dialogue with people, communities, families. And it was necessary renewal when facing the new challenges and conflicts we've lived through in time. Recognizing the important role of promotion equity in health and human development. You also mentioned resilient health systems, health domains, the elements for resilience, and that in our country, in Peru, we have national multisectorial policy for health to 2030 that was agreed with other sectors to intervene in the social determinants of health with the comprehensive care life. Dr. Rosell, thank you so much for your intervention. And we'd like to take this moment to thank all those who are participated in this virtual event from Argentina, Belize, Bolivia, Chile, Colombia, Cuba, Ecuador, Spain, Guatemala, England, Mexico, Nicaragua, Paraguay, Peru, Uruguay, Venezuela, among others. We also received many greetings and many questions. And please, at this moment for the Q&A, I will kindly ask you to start your videos, and we're going to go on a brief Q&A because we're running out of time. And Dr. Campodónica has difficulty with the internet connection.
Doctor Boji Eliancén
For Dr. Boji, we have a couple of questions for you. What are the opportunities for South American countries to recover and position the ancestral knowledge as part of the technology to approach health determinants? What would be the priorities to strengthen digital health and transparency of health systems that are fragmented and segmented? Thank you. Thank you. I believe that Latin America has a strength where they are because digital tools have been developed in recent years. If we look at the European countries and US and Canada, we're somewhat stuck in old thoughts of how to use technology. So in Latin America, you have the opportunity to start not from zero, from scratch, but we have having those complications. And as I mentioned, because there are 500 million people that use Spanish for their health, there is the opportunity to scale up solutions in a format that cannot be done in the world. For example, with digital solutions for primary care. If we want a high technology primary health care that implies an advanced use of biomarkers that can be done quite cheaply, if we scale it to that level, we can connect data to learn not only the individual that looks at yourself, but also to start learning to see aggregated data. But if we want that, we need to collaborate in the country and between countries. And that can only be done with a good governance philosophy, which is what we want to do. And that governance also needs to be applied for the use of data, because data have an opportunity. We may need to make sure that they don't harm the citizen. Thank you. Dr. Campodónico, could you please activate your video? A couple of questions. It is known that climate change is a main threat for health worldwide, in particular in Chile. How this threat affects the 7 strategies for the universalization of primary health care? And what are the most important progress made in Chile with regards to primary health care in the last 10 years? Well, Chile has stated the concern about the issue of climate change. It has signed a number of international commitments to continue decreasing the gas and polluting gas, to improve social responsibility of companies. So climate change not only affects these 7 components of the universalization of PHC, but it affects our life. And in that, there's a holistic look, and it's a relevant topic for life. Now, with regards what have been the progress in the last 10 years, 20 years ago, we had a health reform in the government of Mr. Lagos, and a health reform that made emphasis in primary care. Therefore, there was a major development of infrastructure. At this time, primary health care officials talk about their clinics because these are large buildings with a pleasant environment. We have created community health centers in the populations that are smaller health facilities. We lost the audio. Dr. Lidia, perhaps if you stop your video, we can't hear you. Yes, sometimes we have connectivity issues. We will wait a few seconds or we will move on to questions for Dr. Rosell. We're all running out of time. Okay, so we will move along with Dr. Rosell's questions. We have selected 2 questions. What are the most important challenges for collaboration between the population in health system and other sectors that are relevant in order to build? Dr. Campodónica, maybe you can finish your answer. Training of the teams has been promoted, and by the implementation in this context of the reform, the comprehensive care resulted in the creation of a consortium of university to provide training the primary healthcare workers, and therefore there's been major progress, and the health system is continuously changing, and now the major challenge that has us very excited is the universalization of primary health care. Without, regardless of the health insurance, it just has to be a person and therefore can have access to care. Okay, thank you, doctor. For Gustavo Rosell, I start reading the questions. What are the most important challenges for the collaboration between the population and the health system and other relevant sectors to build an adequate primary health care in Peru? Are there any experiences that have solved these challenges? What are the lines of actions to prioritize to make an effective application of this policy of comprehensive health policy for the year 2030? Thank you. Briefly, because of time, these are very important questions that would take us hours to discuss, but there are some positive experiences in Peru. The Ministry used to organize through the Health Promotion Office the presentation of collaborative experiences, and it is the core responsibility of the citizen, of all the people that we have with our own health, but also with the health of the community. I remember the experience, for example, that we had a district in San Martin where there was no dengue, but that was surrounded by dengue. Didn't have any dengue cases. Why? Because children learn not to have these breathing areas. They were themselves responsible of not having these mosquito breathers. There was no single paper or cap in the floor. You see the trash cans, and people will use the trash cans. We never had to fumigate. We never had to do other interventions that was promotion of health. One example among several of how the population participated in child nutrition. I had mothers that were charged of weighing their kids and measuring their stature. And the same with anemia. We had a participation of many health promoters through Goal 4 that you can look in the Ministry of Economic and Finance. We provide a stipend to the promoters that they could visit children. I spent hours talking about experiences, but there's ways in the different regions of Peru that can provide us orientation of how can we coordinate with the community and people. On the other hand, there are challenges. Of course, one of the major challenges is human resource, not only in number, because we are way below the number needed, so people are saturated dealing with diseases, but not generating these spaces for the development of people caring for the people's health. And also the competences. We are trained to treat diseases. We're trained to work in a schedule of a health facility. So we need to change that mentality. It's difficult. So we need a convincing health staff to decide to go for health promotion and not treating the disease. And also the way we finance public health, something that needs to be discussed, because the comprehensive health insurance, as you know, doesn't cover all the needs and there are many deficiencies. So we need to review this element in addition of how we are interacting and looking at the quality indicators with regards to primary care. There are many things, other things to discuss. Thank you. Final question for both of you. Can we say that PHC is obstructed by economic systems or other models? How can we make primary health care sustainable and reduce the vulnerability in facing the change of power or economic models? Dr. Boji?
Sí. Yo creo que hay
I think that there are several issues to consider, and they have been mentioned. Part of it is what do we want to pay for and how. We have a fascination for advanced clinical treatment, and we want to pay for that. We don't have much will to pay for things more simple, that Dr. Rosell was explaining, that have greater impact at the population level. So we cannot blame the politicians. We need to change mind and what do they give value to. And there, that needs to be changed by the politicians. That's a mindset shift and a change of paradigm. Having said that, how we need to change the criteria, what are we paying for? We pay for infrastructure to have traffic. Why can we pay to maintain health? We need to think differently. We need to consider other outcomes. If you ask me if that's going to happen, it is going to happen. But the important question here, if our health systems throughout the world need to go broke before we make the change, or can we do it before we get to that catastrophe? Thank you. Dr. Rosell, a comment? Yes, I back up this comment. We need to invest people in more trauma specialists or to prevent accidents in the street. Yes, we do need both, but we need to focus our effort, our resources where we're going to be more efficient and prevent the suffering of people. That has always been our position as health staff, to prevent disease. Although sometimes it's more simple and we decide to go to a public health institution, hire more staff, more work in the office, and not consider the real purpose of health. Thank you. All right. We thank for the questions. Unfortunately, there's no always time to answer all of them. That they always used to define new topics for the following seminars. We value your participation and interest. And to close this space of Q&A, I will ask each one of you to give a final message in 1 minute, and we will close this space. Yes. First of all, I would like to thank you for having this webinars, but also for the work that is trying to connect people at certain different levels. That is not the only thing we need, but this is something major and extremely important to do, and also to connect and learn from each other in order to get to more sustainable solutions. It's something I really appreciate, and it's been an honor to participate. Dr. Rosell, your final message, please. Thank you. Thank Mari Carmen and the team for having this topic present. So important primary health care and essential care, which is current topic despite the years have passed, part of the pending agenda of how we need to organize our health. It's not a utopia, a theory, something that we really translate in concrete actions, in policies, in strategies, in models, but above all, in actions and interventions close to the population. Thank you very much. We reiterate our thanks to the excellent speakers today. We received many congratulations in our social networks. Thank you very much, Dr. Boji Lencen, Dr. Linia Campodónico, and Dr. Gustavo Rosell. to all the participants of the Horas Conu team, and to all the people who participate in this activity, which has been possible thanks to the commitment with the Andean and Latin American integration. I give the floor to Dr. Maria del Carmen Calle to close this webinar on behalf of the Andean Health Organization and Politunan Agreement. Go ahead, Dr. Calle. Thank you, Maria. Well, my first words are to thank our three brilliant speakers. Primary healthcare is here to stay, has renewed itself. But I remember my first contact with primary healthcare when I was doing my social service. So you can realize how old I did CECIGRA, now it's called Serums. And if I'm not incorrect, it was in the 1980, and I was in the El Ermitaño Health Center. And my chief was Dr. Amati Leon, that had just came back from Israel after getting her master's degree with primary health care. And this was very clear for us in the sense that it was care, not only attention, but it was care. And it was to get health close to people. I remember that was the motto, get health close to the people. And as Gustavo mentioned, health doesn't start in health services, health starts at home. And with this dynamic between home, school, family, community, and everything else. Health is done at several scenarios. Now, the renewed primary healthcare has added some important topics, but it still conserves its roots, which are solidarity, equity, social justice. Is to see that there's no inequality or gaps in our relations. And I think that model of primary health care is given at every level, and it is the look from the promotion with the social determinants up to the rehabilitation and promotion and palliative care. So today's meeting has been magnificent. We've heard many important things, but the most important thing is we heard of actions that are being carried out. And the Institute for Future Studies, the reality in Chile and the reality in Peru. There are many things that have been done, but the most important, I believe, we should never forget that the person is important, okay, with their needs, with their expectations. And I also coincide that we need to change paradigms. And in paradigms, it's a 50-50. Not all the money has to be for hospitals. We need to have, and not all the money has to be for recovery. We need to think about multi-sectorial in terms of promotion and prevention with more budget. And of course, we cannot allocate thousands of investments to only for the 10% of the population. We very well know that in last minute life is where you spend the most. And if you have prevention, you don't need to spend that much in the last minute of life. So thank you very much for your participation. Very happy. Words of thanks, and we invite you for our next webinar next Thursday at 11 a.m. where we will talk about Mother Earth, because we're close to the Mother Earth Day, and we should not forget that the approach of One Health is valid. We are not alone. We are part of a context and human health, animal health, and of course, everything that has to do with the environment. We cannot stop mentioning that climate change is one of the things that most influences health at this moment. Thank you very much for your time. See you soon. Bye. Thank you, Gustavo.